Okay. So today we're talking about Marcus Jackson, a 34-year-old African-American male. He's here today with some mental health symptoms. He served 4 combat tours of duty in the Middle East, which is significant because um, combat tours are associated with significant trauma and the development of PTSD. And he has a 1 year documented history of symptoms including inability to sleep, nightmares, increased anxiety, and isolation. The 1 year history indicates that this is not an acute anxiety exacerbation. The four main PTSD symptoms are reliving the event, avoiding things that remind you of the event, having more negative thoughts and feelings than you did before the event, and feeling on edge or keyed up. And Marcus is presenting with all four of those categories today, indicating that he is likely experiencing significant PTSD as a result of the trauma he experienced in combat. He's experiencing nightmares involving reliving the images of explosions during combat that sent body parts flying through the air. His friends were killed, and the incident left him blind in one eye with a permanent limp and chronic pain. Nightmares that involve reliving the traumatic events are a hallmark sign of PTSD, and the permanent disability that Marcus now lives with also serves as a constant reminder of the trauma that he experienced. He startles easily due to loud or unexpected noises, which trigger extreme anxiety. They remind him of the sound of gunshots and explosions when he was in the Middle East. And the anxiety and trauma is causing increased isolation. He spends a lot of time in his room alone watching TV and avoids spending time with his wife and children. This is common with especially veterans that have PTSD. They feel like people can't relate to what they have seen and done in combat, and so they do tend to isolate themselves when they are experiencing these exacerbations of the PTSD. He's experiencing significant survivor's guilt and stated, "I should have died and not my friends." And while survivor's guilt is a common occurrence in people who, especially are sole survivors of a traumatic event, this is concerning and may be indicative of suicidal ideation. So that's worth further investigation. Relevant data from his social history. He's been married for 14 years. They have 3 children. These are significant protective factors against suicide, in that he has a family and he has a supportive partner. He has no history of physical aggression, but his agitation and nightmares have gotten progressively worse with each tour of duty and since his discharge. Um, that is likely a result of the exposure to repeated trauma and experiencing injury during combat. He has a history of problem drinking, but has been sober for a year and a half and denies any other substance abuse. And he experiences nightmares, again, involving reliving the trauma of the explosion that killed his friends and left him disabled. These nightmares and flashbacks can happen at any time, and they can feel very real and very scary. Um, and he has gone days at a time without sleeping. As far as vital signs, all of his vitals are within normal limits. Even though he is experiencing extreme anxiety, which could affect his blood pressure, his respiration rate, and his pulse, everything is currently normal. The only abnormal thing reported was his pain level due to the explosion that left him blind, and he ended up with shrapnel in his stomach and left leg, and has had several abdominal surgeries and reconstructive surgeries on his left leg. He now has currently it's a 5 out of 10 continuous aching pain due to the damage sustained to his left leg that is worse with movement. That's it.
I think that was a great assessment. Thank you.
Thank you. Okay, so we can move on to the physical assessment data. For relevant physical assessment data, he appears anxious, his body is tense, he's tired, he has dark circles under his eyes, he has a flat effect, he has an inability to fall asleep and stay asleep, only averaging about 2 hours of sleep per night. And like Caitlin said, he's having the nightmares and the flashbacks while awake, nightmares while asleep. So these are physical and emotional signs that can result in lack of sleep. Not getting adequate sleep can further exacerbate a patient's symptoms of PTSD and lead to exhaustion and depression. When a person is not getting proper sleep, it takes a toll on their daily life. And yeah, the nightmares and flashbacks can add to his inability to fall asleep or stay asleep. He walks with a limp. He has the facial scars. These are concurrent findings with his history of like in combat, and it could add to his depression, his social isolation, and then just a constant reminder of his disability. And also the friends he lost there. So yeah, just a constant reminder of what happened while he was in combat. And then let's see, his GI, he reports a poor appetite. So not getting adequate nutrition can cause a decline in one's sleep and exacerbate other health conditions. So I'm curious if his poor appetite is due to wanting to be alone. Is food associated with social interaction for him? And so maybe that's a part of it, maybe. And then it's crucial to know his history of alcohol use a year and a half ago. If this PTSD symptoms are unregulated, it could cause him to relapse and go back into that um, maladaptive coping habit. And then we'll move on to his mental statics exam. Again, he feels anxious. He says he feels nothing. He flies off the handle easily and startles easily. He's somewhat guarded in his response, but admits to intrusive thoughts. He's expressing guilt that he wasn't able to help and that good men died. He's having the flashbacks of the IED blasts and sees flashes of those body parts. So these are all crucial because let's see, anxiety, flat affect, intrusive thoughts, and extreme survivor's guilt are all acute exacerbation of his symptoms of PTSD, and they increase his risk for violent behavior towards self and others and can further increase his anxiety and depression. Let's see, he recognizes his symptoms as PTSD but does not think anything can be done to help. So, hopeless and negative thinking can lead to poor patient outcomes. So, because of this, the healthcare team should provide him with hope that he can get better and make him aware that there are options to manage this. So, therapeutic communication. Let's see, some memory problems associated with the exact events, and he reports some concentration issues at times. So I think that further assessment of a possible TBI from the blast could be crucial to understand kind of what's going on with his brain, aside from the PTSD. He tends to stay to self, so he's isolating himself, which can lead to further depression and risk for self-harm if further unregulated. And then lastly, he states he should have died instead of his friends. He denies current suicidal ideation, but this could lead to a risk of injury or death to himself if thoughts of death in the guilt progress. Okay. Any input or questions? No. Okay. We'll go on to diagnostics. So for his BMP and CBC, all of these values are within normal range. Same with the urine drug screen and then the screening for the Tylenol and aspirin. Let's see. So, but all considered significant. These are like kind of gold standard diagnostics, but continue to monitor. The urine drug screen and the Tylenol and aspirin just are signifying that he's not using any drugs. He's not using any drugs. So it's fully the PTSD that's causing these um, issues that are going on with him. And yeah, that's what I have there.
I like how, going back to the nutrition, I like how you said that eating food is associated with social interaction. I just wanted to point that out. I don't have any other ideas about that right now.
Thanks, Mariel.
I think that was a really astute evaluation, and perhaps that gives me some ideas for how we can adapt the therapeutic milieu to accommodate that increased anxiety that might be associated with social interaction, like during meal times, if that is the case. So just definitely gives us some good points of consideration for how we can create the safest, most supportive environment possible for him.
Yeah.
Yeah. I think something I also wanted to point out is that you highlighted that, let me see, he recognizes his symptoms as PTSD, but doesn't think that anything can help. So I think that this presents us with a really great avenue to kind of encourage him. And I mean, he used to drink and doesn't anymore. So we could combine those and say, sort of the motivational interview stuff of, well, you don't think anything can help, but why didn't you go back to drinking? And then try and get him to really build himself up and recognize that he is in control of what he can do. Um, and hopefully that will help him sort of recognize that he can be an active participant in getting things better for himself and really participate in his own care.
Yeah.
That's excellent. I mean, I think it provides a really solid avenue for approach to cognitive behavioral therapy because it sounds like he'll benefit from cognitive therapy's goals of reframing these negative thoughts or negative associations that he has ingrained in his mind. And if we're able to encourage him to adopt a new means of just reframing his context, his thoughts to eliminate those intrusive thoughts and influences, I think he would be a really great candidate for that therapeutic approach. So I guess we will move on to discussing the pathophysiology of Marcus's issue. I think we've all been able to recognize that his primary issue is that he is experiencing severe PTSD exacerbation with associated insomnia, nightmares, flashbacks, hypervigilance, and intrusive thoughts. His symptoms are further complicated by chronic pain and psychological distress, including survivor's guilt. I think there was a lot of really important emphasis on the survivor's guilt and the avenue that that can create, especially in the setting of an individual who is a veteran, of being at an increased risk for self-harm, particularly suicide. Because those, if left unaddressed, those complex feelings can definitely erode somebody's will to live daily. So the pathophysiology is that PTSD develops when the brain's natural response to trauma becomes hyperactive, resulting in persistent symptoms of re-experiencing the traumatic incident, heightened arousal and avoidance triggers, overactivity in the amygdala, which is like the lizard brain, heightens fear responses, while the prefrontal cortex struggles to regulate these reactions. Impaired memory processing by the hippocampus contributes to intrusive thoughts and flashbacks. And these changes maintain a heightened fight or flight state, disrupting sleep, creating emotional instability, and impairing concentration. The added survivor's guilt creates additional emotional strain, increasing the risk for depression and suicidal thoughts. So how are we going to manage his care? Moving on to discussing medical management, rationale, and an expected outcome. When I was formulating an expected outcome for these various interventions and the rationale, I was thinking in the context of what would we like to see by the end of the first day in treatment, because that's a really big step, and what would we like to see ideally by the end of the first week. So I definitely welcome a conversation of where can we realistically place our expectations for his participation in care. So admit patient to unit under voluntary admission. So right away, this is very encouraging, because voluntary admission is definitely preferable to involuntary admission. You're going to more likely see a patient that is ready to participate in care at a baseline. The voluntary admission to the unit itself, the rationale is it's going to provide Marcus with a structured and supportive environment to address his PTSD symptoms in a safe setting. This approach encourages active participation in treatment, promoting autonomy and collaboration, especially among individuals who might be experiencing very similar struggles, being as how this care is taking place within the VA. Marcus will have access to specialized care, including therapy, medication adjustments, and supportive interactions with staff and peers. This stable environment reduces external stressors, allowing him to focus exclusively on managing his anxiety, improving his sleep, and building resilience, which is really what we want to see from him right now, while fostering trust with the care team and the process of engaging in effective treatment and ultimately recovery. So the expected outcome, by the end of the first day of admission, Marcus will verbalize understanding of the treatment plan and demonstrate willingness to participate in at least one therapeutic activity, such as meeting with a therapist or attending a group session. By the end of the week, I think it would be advantageous to see Marcus participating in 1 to 2 therapeutic activities on a daily basis. And once we establish a baseline for how his symptoms present, maybe we can focus a goal on symptom reduction in terms of nightmares or social isolation. Maybe we set a goal for him to engage in a meal among his peers once a day or twice a day, just depending on what looks realistic after assessing his baseline. The next intervention would be to initiate milieu therapy. The rationale for this would be milieu therapy provides a safe and structured therapeutic environment that is essential for reducing isolation and promoting a sense of connection and support. The therapeutic setting facilitates positive interactions with staff and peers, which are crucial for developing coping skills, improving emotional regulation, and building social connections. By fostering a sense of community, this approach helps Marcus feel supported and less isolated in his struggles. I think it's going to be very critical to emphasize that he doesn't need to sit alone with these feelings, and there are others enrolled in care that can relate to him and are at a different point in their journey on the care continuum. The structured routine will provide him with a stable and secure foundation, allowing for him to concentrate on effectively addressing his mental health concerns. By the end of the first day of admission, Marcus will report feeling safe in the unit environment and will engage in an initial one-on-one interaction with a staff member to discuss his concerns and treatment goals. And by the end of the first week, Marcus will have actively participated in at least one group therapy session per day, demonstrating increasing engagement in therapeutic activities aimed at reducing isolation and anxiety. Our third intervention would be initiate safety measures according to unit protocol, including keeping the environment free of dangerous items and maintaining regular close observation. Implementing safety measures such as routine observation and maintaining a hazard-free environment is crucial to ensuring Marcus's physical and emotional well-being, primarily his physical safety. Regular monitoring allows staff to promptly identify and address signs of distress or escalating symptoms, while a hazard-free setting minimizes risk of self-harm or harm to others. these precautions not only protect Marcus, but also create a sense of stability and security, which is essential for his recovery. Since we know that Marcus has an increased startle reflex, I think part of his safety measures are going to be making sure that not only are dangerous items out of the unit, but we are very mindful with loud noises or potential sources of overstimulation for him, as this could definitely push him into a hypervigilant and anxious state that would be detrimental to his treatment progress. By fostering a safe and supportive environment, Marcus can begin to focus on addressing the root of his PTSD and engaging in effective symptom management. So, an outcome would be Marcus will remain free from self harm throughout his admission by adhering to safety measures, collaborating with staff during the initial safety risk assessment, and actively following unit protocols to maintain a safe environment. I think a appropriate goal for the end of the first day of admission would for us to confirm that Marcus can verbalize what the standards and expectations are for maintaining a safe environment, what is and isn't allowed inside the unit. And I think this will also facilitate communication with his family, what they can and can't bring in when they come to visit him. Our next intervention or medical measure would be vital signs every shift while awake. This is appropriate because it contributes to regular monitoring, and regular monitoring of vital signs help us detect physiological stress, including increases in heart rate or blood pressure, which can signal worsening anxiety or pain and enable us to employ timely interventions. Further, I imagine that Marcus will begin medication therapy, which I know that Kat is going to discuss in greater detail in a moment. But while he is initiating treatment with these medications, it will be imperative to monitor his vital signs to make sure that we're not seeing any sort of adverse side effects related to the initiation of medication. Our goals or outcomes would be by the end of the first day of admission, Marcus's vital signs will remain within his baseline range, with no documented episodes of significant dysregulation. Ideally, his first day, his first week, we're going to want to identify what his normal is, where he sits at. And by the end of the first week of treatment, Marcus will continue to maintain stable vital signs within baseline range, reflecting effective management of anxiety and pain, especially in the context of initiating medication treatment. So if anybody has anything they'd like to add at this point, I'm all ears.
I don't have anything to add. I think your information here is very detailed, and I like how you came up with a first day outcome and a week outcome, because that's really thinking about the big picture. So, really great job.
Thank you. So I guess we'll transition over to Kat.
Cool. Yeah, I do appreciate you highlighting that vital signs will be important for medications, because we certainly have some adverse effects and serotonin syndrome stuff that we want to be watching for, and vital signs will be huge for that. So, the first one to talk about is paroxetine. Marcus is prescribed 40 milligrams once a day. This is an SSRI, so it's an anti-anxiety medication. It's also an antidepressant, anti-obsessional, and anti-panic med. The way that it functions is to block serotonin reuptake within the central nervous system, so it prolongs the action of serotonin within the synapse. And it's indicated for PTSD, so this is why we're seeing it being prescribed to Marcus. The two expected outcomes that we have here, the first is that Marcus will comply with treatment and he will be taking 40 milligrams once a day, so we expect to see him take it by the end of this shift. We also want to make sure that we are providing education. So another outcome will be that Marcus will report an understanding of the education. particularly including the key features of why he's taking it, the importance of reporting suicidal ideation, because we can see that increase with the initiation of an SSRI, and the fact that it may take up to 4 weeks to see any changes. So that'll just help us make sure that he understands what's going on with the med, and what he can expect from his end. So the next one to talk about is prazosin. This is 4 milligrams a mouth, so it's actually an antihypertensive. And it functions to lower blood pressure through its selective inhibition of alpha adrenergic receptors and promotion of vasodilation. It's become an accepted treatment option for PTSD, particularly where there are sleep disturbances like nightmares. So that's why we're seeing it being prescribed for Marcus. So again, an outcome is that we expect him to comply, and take 4 milligrams once before bedtime. Um, the education piece of the outcome is that he'll report an understanding, that he knows why he's taking it. He's aware that hypotension is an adverse reaction or an adverse side effect. And he understands that he should move slowly when changing position. Um, and he also will need to understand that it is important to report an erection lasting longer than 4 hours from that vasodilation. The next medication is mirtazapine. This is 15 milligrams by mouth, again before bedtime. So this is a TCA, it's an antidepressant. It functions to inhibit reuptake of both norepinephrine and serotonin within the synapse, so it's prolonging the action there. It's indicated for major depression, which is why Marcus is taking it. It may be helpful for him. Again, we expect that he will comply with treatment and take the 15 milligrams before bedtime. And the education here, probably the most highlighted item, is the risk of serotonin syndrome, especially because we also have him taking an SSRI. So things that we want him to report and things that we'll be watching for are changes in vital signs, GI symptoms, mental status changes, and neuromuscular abnormalities. There's also a risk of allergic reaction. And again, we see orthostatic hypotension, so moving slowly and being aware to stand up slowly. So then we get on to priorities for care. So the very first one to mention is establish a therapeutic relationship. This is both our first priority and the priority really throughout all of his treatment. A therapeutic relationship is the backbone of mental health nursing, and we want to make sure that he understands that we have genuine concern and care for him, that he is being respected in his care, so he feels that he has autonomy and dignity in his care. We want to listen, use therapeutic communication, and make sure that we're doing that throughout the process of treating him. The outcome that we expect here is that Marcus will feel comfortable communicating with the nurse and will express an understanding of the nurse's role in his care. And this can be done in that same conversation where he's expressing feeling safe in the environment and sort of understanding what treatment will look like for him. Another priority is that we want to assess his anxiety and encourage Marcus to verbalize concerns and feelings. So his anxiety is a huge symptom that he is experiencing. We want to make sure that we get a baseline as quickly as we can so that we can really track how treatment is going for him. And we want to make sure that he knows that this is a safe environment to verbalize his feelings. That will help us plan follow-up interventions so we'll understand what is helpful for him, where he could use more support. Things that could also be helpful are like diversion activities and avoidance of triggering factors. So all of those things we're only really going to get information on if he feels good to tell us his experience. So we want to make sure that we are encouraging that. The outcome here is that Marcus will verbalize feelings of anxiety to the nurse and provide self-report of symptoms of anxiety this shift. And that will give us that baseline to compare to. Another priority is social interaction. So we want to be encouraging that, especially in the milieu, we have a good environment to do so. So the rationale here is that Marcus reported altered social interaction, especially with his wife and child. He wants to be isolated and he's spending less time with his family. So while he's impatient, we want to encourage him to attend social gatherings and spend time in the common areas of the milieu. The idea here, again, for the first day is to get a baseline of what social interaction looks like for him, how comfortable he is interacting with people, and what barriers might be making it difficult. So once we have that information, we'll again be able to plan more interventions and follow up. So the goal for this shift is that he will participate in one social gathering in the milieu. And that could look like mealtime, it could look like a conversation with staff or really anything. For the first day, we just want to see any sort of interaction. So the next priority is we want to establish coping behaviors. So it'll be essential to establish what coping behaviors he's currently using and how effective they are, what his experience with them is. It's likely that we're going to want to add more coping behaviors, and it'll take some time to identify what will be helpful for Marcus and what that's going to look like for him. This is important because when he does have that startle response, when he does have that really quick increase in anxiety, we want to make sure that he feels prepared and he has the tools to self-regulate and cope with the heightened emotional state. So by the end of this shift, we want Marcus to verbalize the current coping mechanisms he uses and his experience with them. This could also be a really great time to mention, you used to drink and you don't anymore. So that's awesome. Like you've already adapted to that. So let's see what else we can add to it. And then the final priority that I have here is to establish a consistent bed and wake time schedule. And this will be something that evolves over time. And with treatment, there are a lot of things we can do to help with sleep and to facilitate sleep. But I think that the first place we want to start, like when he first gets to the unit, will be just getting a schedule in place. So we're doing this because he does have insomnia. 2 hours a night is not nearly enough. And sleep is huge. So we really want to focus on it and make sure we're addressing that as quickly as possible. So this schedule will be created in collaboration with Marcus. That will help make sure that he'll comply with it and feels good about it. Once we have that going, then we can look at other interventions like, medications, making sure the environment is conducive to sleep. We could also initiate like music or aromatherapy. But the expected outcome here is that Marcus and the nurse will establish a schedule by the end of the shift for when he will attempt to go to bed each night, as well as when he will be woken each morning.
Okay. Well, Kat, that was a really great overview of what we can expect in our nursing priority interventions. I really, really was heartened to see the addition of mirtazapine in particular, because this is a medication that, even though its formal indication is for major depressive disorder, typically it has many effective off-label uses, particularly for insomnia. And one of its known side effects is it is known to enhance the appetite. So use of this medication could definitely solve a couple of problems that are occurring with Marcus, primarily his insomnia and his nutritional deficits that we may be concerned about. With the introduction of mirtazapine therapy, we're going to want to also maybe follow up with the provider about getting a baseline, like getting baseline labs on his cholesterol. And we'll want to make sure that we get his weight and BMI so we can track progress, because even though this would typically be associated with an adverse side effect of the medication, in his case, um, enhancing his nutritional intake would be beneficial. And being able to track that progress will be helpful, but we want to make sure that there aren't negative effects in terms of his total cholesterol. And this medication will be given exclusively at bedtime. If he misses a dose or refuses a dose, it's important to resume treatment the following evening. It shouldn't be given in the morning. And as you mentioned, we'll definitely make sure that we're vigilant to observe for any signs of serotonin syndrome, considering it's his second antidepressant that's going to be messing with his serotonin reuptake.
I have another little input about meds. Maybe because he is experiencing that pain, 5 out of 10, maybe just asking the doctor for the PRN medication and for Tylenol or aspirin that can maybe help him sleep better too. Because when we have pain, it's hard to sleep. So maybe just throw that in.
I like that idea,
Yeah.
especially since we know that he wasn't taking anything to mitigate his pain. And maybe it's the warrior mentality, maybe it's, the cognitive, like the psychological profile of someone who has literally been trained to um, not to show their pain, not to let it surface. But even at 5 out of 10 on a consistent basis, that's gonna wear you down eventually. Like,
Yeah.
and perhaps even like a scheduled um, dosing of something like Tylenol,
Yeah.
because at this point, we don't necessarily know if we can count on him to ask for pain medication if he's experiencing pain. It
Yeah.
might just be best to proactively manage it.
Yeah.
Mhm. Yeah, I think that's a great point.
All right, so now we're going to talk about the psychosocial priorities that need to be addressed for Marcus. Um, the psychosocial priority right now is stabilization of all of the manifestations that we have talked about already. But I think also another important thing is to continue to make him feel safe, since he is having uh, possible thoughts of self-harm. Um, I think the main point here is to really provide trauma-informed care. And so that means asking what has happened to you, not what is wrong with you. Um, this should be like the basis of all of our psychosocial priorities, because it will make him feel physically comfortable, emotionally, and culturally supported in this environment. So, specific ways that we can show that he matters to us is to continue to assess for signs of suicidal ideation, um, because helplessness, hopelessness, self-blame, and guilt um, can inform the risk for self-harm, and it will tell us the level of safety precautions and interventions needed. I know earlier during assessment, he has these protective factors, and like perhaps at the beginning of the shift, he says he doesn't have a plan, but that can always change throughout his stay. So we need to continue to monitor for that. The outcome is that he will share feelings of self-harm whenever they arise during the shift. Another thing that we can do is to use trauma-informed care to reduce the risk of traumatic re-experiencing. So we don't want these manifestations to get worse. We don't want anything to trigger. Um, let's see here. And so a part of that is, so a specific thing that we can do is limit trauma history detail, which to me sounds like as nurses, we are not saying, oh, like, what was this like exactly? What happened exactly? Because those can bring up those strong feelings. Um, and this also requires us to move past any bias for us to self-reflect so that we can provide respectful, non-judgmental care. So by the end of the shift, he will verbalize that he feels respected by the nurses. The third thing that we can do is validate his feelings and normalize manifestations associated with PTSD, such as hypervigilance, intrusive thoughts, or nightmares. This is so important because this reduces stigma and helps promote awareness. He did already state that he's aware of PTSD and what it's about, but it's always good to integrate education. It's always good to keep teaching. Um, so he will share more more about his feelings throughout the shift. Physical comfort measures. As discussed earlier, we always want to promote safety and security. A specific example is noticing signs. For example, if you could say, I notice you're covering your ears. Is there something I can do that would help you feel safe? So that's a specific way that we can like work around that re-traumatizing and addressing it and helping him feel safe. I don't know how to explain myself with that, but um, and so an outcome is he could identify an adjustment that could be made in the environment, such as lowering the TV volume. I think this is a really important one. Ask Marcus first if it is acceptable to physically touch him and verbalize the reasoning for it. This is very important for people experiencing trauma because it can trigger that sympathetic nervous system, fight, flight, or freeze. It can be perceived as uninvited, threatening, or unwanted, or violating. This will empower him and make him feel like he's in control. This is also especially important since he is blind in his left eye. So being aware of that too. So Marcus will verbalize that he feels in control of his own space. The third thing is consider any possible triggers and keep noise levels low. We can do this by keeping his door closed, again, depending on his SI assessment, providing privacy and considering the location of the room. So trying to keep it away from the busiest, loudest part. It's important to keep the noise levels low since noises are triggering his anxiety and flashbacks. This will also address his lack of sleep. So Marcus will sleep for at least 8 hours during the shift. And then I was thinking of um, adding something about inquiring about the need for assistive devices because I was just thinking about his painful limp. I don't think it's necessarily a priority right now, so that's why I was iffy about adding that.
I like where your head's at though. Maybe not necessarily like assistive devices, but if he's up for it, maybe we submit a referral for PTOT because not only can they assess him, they can give us some good points for how we can physically interact with him or how we can alter his space to be more conducive to his abilities. I think you're mentioning the being particularly cognizant of the noise levels. And I love that you mentioned the blindness in his left eye. That's going to change how the nursing staff and support staff approach him because approaching someone with PTSD from behind is already a no-no. But to those who may not be familiar with his past medical history, he has reduced peripheral vision due to the blindness in his left eye. So he may be more prone to being startled if someone is approaching him from, you know, like from his left side. And that may contribute to an exaggerated startle response and increased anxiety. So we'll have to make sure that we communicate with the staff about that.
Yeah, thank
I
you.
think, yeah, I think that's a great point. Um, Thinking about the limp, we mentioned pain medications might be really helpful. Um, it may be a good thing in that OTPT referral just to get an idea of what his like safety level with the limp is. What does his gait look like? How is he adapted? Um, it may be that he has adapted relatively well and doesn't need any sort of intervention in terms of assistive devices or fall risk stuff. But we want to make sure that any of those adaptations that he's made for himself at home, we're also replicating in his environment. So, like, if he has his chair a certain way so he can approach it from a certain side, we want to make sure that we are facilitating that. Um, Another quick thing I wanted to add is regarding the outcome for his sleep. Since he has only been sleeping about 2 hours a night at home, I think 8 hours might be ambitious. So maybe during the shift, we aim for like 4 or 5 and see how he does with that and then sort of progress from there.
I think
Awesome.
that's a good point, Kat. Like, I mean, I would love to get 8 hours of sleep at night.
Yeah.
And I think that we can get there, but in the spirit of, you wanting to emphasize like the accomplishments that he has already made, we don't want to necessarily set him up for a goal that he may not reach because I think he's susceptible to feelings of failure. And that's not one that, I mean, maybe many of us could easily achieve. Um, the PTOT referral also might provide an opportunity for us. Like that's another staff member interacting with him and potentially having a positive interaction with him. This is a conditioned soldier. This is someone like who is required to be in peak physical condition prior to um, their trauma. And he may still have a really, really helpful response to exercising. So, someone kind of facilitating that activity might be in a better position to have a therapeutic conversation with him. And any individual he engages with is going to be advantageous for his care team overall.
I think in addition, sorry, are you
I
done?
was going to say, maybe we'll learn something new.
I think in addition to his physical needs, potentially with assistance, also his emotional um, need for positioning within like the facility and within group settings, not having his back to the door, being in a safe position when he's around other people, assisting him to find, a seating within the group that makes him feel secure, like nobody's going to be able to come up on his blind side and startle him. So figuring out how he can feel safe while interacting with others within the facility is going to be really important.
It's a really good point, and that will be a key component of making sure the therapeutic milieu is um, holistic and patient specific for his needs. So I really appreciate you bringing that up.
Yeah, thank you, everybody. I appreciate all of it. Anyone else have anything to add for physical or caring comfort?
I think just making sure we include his family in the teaching too, so they know how to approach him too. I'm sure they're used to it. They live with him, but just encouraging them to also like just letting them be aware of what can help him as well, since the goal is for him to go back home eventually.
Good
Yeah,
call.
that's a really
That'll
good.
include things like, teaching his kids, like, hey, don't come up on dad's left side, right? Like, it's going to be adjustments for the entire family
Absolutely.
to help him not isolate himself so much.
Yeah.
All right. So then next part is emotional support, things that we can do to develop a therapeutic relationship. So a part of trauma-informed care is being aware, sensitive, and responsive. An example of this is using open-ended questions because it empowers the client to engage in care rather than create an environment of coercion or forced complicity. Complicity. Um, so I think this is also important for people that have experienced trauma because, and that's a part of being sensitive. You don't know exactly what they went through. Perhaps they didn't have control. So giving them that power back in this environment. So he will engage in care by responding to assessment questions during the shift. Um, Another thing is to allow him to make choices in his care, such as choosing meals or allowing timing of activities of daily living. This will help empower him even more, as mentioned earlier. This will help him have more choice and control. This is especially important since we were talking about his nutrition. We can improve his nutrition by allowing him to have those choices. So Marcus will choose when to have his meals and shower during the shift. Provide clear and consistent information regarding nursing, hospital routines, and rules in the plan of care. This avoids overwhelming Marcus and helps reduce his anxiety and maintain a sense of control. So he will ask questions regarding his plan of care during the shift. Identify and emphasize positive coping skills and relationships. Um, Something that Kat brought up earlier was um, telling him what he is doing well at, such as not drinking for the past year. Um, that's a positive coping skill, or like continuing to motivate him with the things that he's doing good at. Um, so this helps identify and reinforce healthy coping mechanisms. Um, we can also teach him other coping mechanisms such as grounding or breathing. So an outcome is he will use coping mechanisms such as grounding. Spiritual care support, assess for any spiritual or religious practices or needs because he has not identified any spiritual practices or needs at this time. This is super important because these things can help mitigate the effects of stress and PTSD, and we can connect him with services such as the chaplain or other spiritual resources. If he has spiritual practices, he will use it at least once during the shift. Cultural care source and support ensure the use of cultural humility. So again, it's instead of asking why are you here or what's wrong with you, it's asking what has happened to you. And a part of that is learning more about his experiences in the Navy and thinking about how stereotypes, biases, and how these things can shape his experiences and perspectives and health-related behaviors. He hasn't identified any specific cultural needs at this time, um, so we need to continue to assess for that. And a part of trauma-informed care is also realizing that like being in the military or the Navy and being a veteran is kind of like a unique culture in its own. Um, so we will inquire about his cultural environments in order to help connect him with community resources. Um, so like for example, during active duty, veterans can be expected to develop self-discipline and to control their emotions and physical selves. So being aware of that too and how that impacts his health behaviors is important. And it'd be important to learn more about his thoughts about these things because it can help us determine what type of therapy would best benefit him and what resources would benefit him. All right, that's that for spiritual care and cultural care. Anyone have any thoughts?
Regarding the intervention for the spiritual care and support, uh, because what would your plan be like if Marcus doesn't necessarily have a you know a identifiable source of spiritual care or support? Um, like if that is not a big part of his life, then what intervention or outcome do you think would suit that kind of situation? Or is there another outcome that might encompass whether or not he has that outlet in his life?
Yeah, no,
I I have an idea about it. I think when I think of spiritual care, I think something that we're really talking about is what is meaningful and what's like meaning making to him. So if he is not spiritual, then it may be about just finding what is important to him and meaningful. So that might be something like connecting with other veterans and being able to really immerse himself in that culture. It may be something like spending time with his family, maybe having them visit. Um, if he really enjoys exercise, it could be making sure he gets an hour of like dedicated exercise time a day, sort of whatever it looks like. I think the goal will be to figure out what is really feeding that sort of worth making part of him. So,
That's a really great summary, Kat. Like because we don't want to necessarily turn him off to identifying like those influences in his life, like what really inspires those feelings. If it doesn't look like something that we put in a box, like he's not going to find that from a chaplain or a religious service or meditation. I mean, maybe it's going to be connecting with those really important people, like that truly understand where he's like coming from. And I really like how your explanation makes room to accommodate what he's really about.
mhm. Yeah, I love that. Thank you for, yeah, I felt stuck with that, so I appreciate that.
That's okay. We're all here to support each other.
All right. So now for educational discharge priorities, the first step is to always confirm with the patient about who is involved in his plan of care, such as his wife, because that can always change throughout their stay. And then, and the next priority is educate Marcus and his wife to continue to watch for the risk of possible self-harm since he made that statement, I should have died instead, by creating a safety plan, identifying thoughts of suicidal ideation. Um, and then I think another very important part is it is important to educate the family and Marcus that healing from trauma is a slow and challenging process, that recovery takes time, and the best way to recover is to have support from his family members and to help increase his confidence, self-esteem, and hope. Um, As mentioned earlier, he states he is already aware about the clinical manifestations of PTSD, but again, we will continue to do that for Marcus and his wife and his family as well. We will encourage Marcus to continue to have open communication with his wife and family because research suggests that reconnecting clients to positive relationships is vital to resilience. We will also encourage Marcus to continue to collaborate with case managers and social workers about community health resources such as therapy, to help with that anxiety, depression, and effective coping mechanisms, and also attend veteran support groups. So, really building that community so that he has that emotional and cultural support. Um, Again, I think it's always good to end on a good note that he's doing a great job of seeing his PCP. It sounds like he has been doing that for the past year, and not drinking alcohol, and to continue to motivate him to do these things because they will help in the healing process, especially help with his chronic pain. Um, I'm also going to add in there to incorporate his wife and kids about how to approach him because that's very important with PTSD. Yeah, I feel like to sum this up, we've identified some protective factors for Marcus, and he um, has been seeing his primary care provider. He is aware of what PTSD is. So I feel like overall things are looking up for Marcus.
And just the fact that he's voluntarily committing himself to this program, like that's a huge first step. So it really underscores the fact that he is ready to engage in immersive treatment and therapy. So even if he doesn't necessarily believe that he can improve his situation, I think by really aligning expectations, as you guys have mentioned, and like emphasizing that healing from trauma is slow and it's hard, and he's doing a great job already. Like he, hopefully with this ongoing encouragement, he can eventually see how big of a hurdle he's already overcome just by being here.
All right. Does anyone else have anything to add to the discussion today? Nope. All righty. Well, thank you guys so much for everyone's hard work, inputs, and thoughts into this.
Good job, everyone. I think we have a really great plan of care.